Okay, everyone, Chapter 11 is going to talk about claims, denials, and appeals. Healthcare claims are what tell the payer what a provider did for a patient, right? We always want to have a clean claim, meaning no errors or missing items, because then your claim can get denied and you don't receive payment for the services that you provided. And so we're going to talk about some of the most common reasons for denials, how to avoid denials, and how to make an appeal. So on a claim, there are usually several different service line items. Everything a patient has done to them will pretty much be on a separate line item. So lab work, medications, x-rays, etc. For each of these line items, the payer can either pay it, deny it, or pay it at a reduced rate. Okay? So they can pay for some line items on a claim and deny others, or vice versa. A billing error will result in a denial or payment, and there are three types of billing errors. So first is when there's an error to coding linkage and medical necessity. So like if the patient has a service that doesn't match up with what their diagnosis is. The second is an error related to the coding process. So if they use an outdated code, or worse, if they report services that aren't documented, or alter the documentation after the services are reported. Those are all big no-nos. And there's a lot more examples for that one. But the last one is errors related to the billing cycle. So billing for services that are not covered, unbundling, which is billing for all the parts of a service separately when it should be billed together in order just to get more money, or using a code that gives higher reimbursement than the correct code. Okay, things like that. Denials usually fall into one of 9 categories, which we're going to go over next. But the best way to try to reduce how many denials you're getting is by first making sure you know what types and categories of denials you're getting. That way you can focus on whatever area you're getting the most denials in, because maybe it's just a training problem and you just have to retrain or re-educate the coders to do it the correct way so you no longer get those types of denials. All right, the first one is medical necessity. You've heard me say those words a lot by now. This type of denial happens when the procedure doesn't match the diagnosis, or it's not provided at the appropriate level of care. Missing information, so you have to make sure everything is on the claim that the payer requires, or it will just automatically be denied. So you never want to leave anything blank that's supposed to be there. Contractual obligations. So when you go into a contract with a payer, there are going to usually be these contractual obligations that are set, just things that you have to do a certain way. So if these aren't met, then you can have a denial. Insurance eligibility. So when a patient is no longer covered by an insurance company, but the doctor's office maybe didn't verify this before seeing the patient, then the insurance company is going to deny it. Non-covered charges. So remember, insurance companies will have those lists of all the services they cover and how much they'll pay for it. So if you bill for something that's not on the list, they're going to deny it. MSDRG coding. When there's one code that raises the DRG, remember, if the DRG goes up, the payment goes up, then the payer is going to look at it extra close just to make sure it's legit, right? Because they don't want to pay more money than they need to. A clinical validation error happens when the payer thinks a coded diagnosis doesn't have enough evidence in the chart to prove that the diagnosis was accurate, basically, that the diagnosis or the patient's condition maybe wasn't that severe. An invalid code denial is when there's a code used that is no longer valid. And then missing records denials happen when a payer requests medical records to look into, something, and the provider doesn't send them in the set amount of time. Okay. Most facilities will have a denials management program to prevent denials and like recover any denied payments. So the program will focus on the things listed here. So preventing further denials, recovery of lost money, providing clear work guidelines, processes, and procedures, investment in staff training and education, and utilization of technology to assist with process. Okay. And that last one is things like tracking the denials, having it automatically sort by payer type, identifying trends, things like that. Okay, facilities are using analytics more now to provide a more comprehensive and systematic approach to finding out what's causing the denials, and just to be able to look at trends. Analytics can also do denial prediction, so you can try to fix whatever it is before ever sending the claim to the payer. Like it can flag like, hey, this doesn't look right, it might get denied, pay attention to this. Okay. CARCs, C-A-R-C-S, are claims adjustment reason codes. They are on the explanation of benefits, which if you remember, that's what the patient gets after the insurance company makes a payment on their health claim. So the CARC explains why their claim was paid differently than how it was billed. RARCs are remittance advice remark codes, and this is just the same thing but on remittance advice. So that's the document the physician gets with the payment, right, for all the claims. Okay, so same thing, that's just on the doctor's side. Denial management programs use root cause analysis a lot. When there's this problem, we need to figure out what's the root cause, what's the original reason that we have this problem, so that we can fix that. Okay, this way they're not putting a band-aid on or just having like a temporary fix. They're solving the problem from where it starts, so they don't have to deal with it anymore. To do a root cause analysis, they have to determine what happened, why it happened, and the likelihood of it happening again. Okay, tracking is another part of managing denials. So with all of the information you collect, you can identify those patterns or trends, so that, if you need to do more education, you can do that, figuring out what the problem areas are. Okay, so if you get a denied claim, you can start the appeal process to challenge the payer's decision to deny or reduce the payment of the claim. Each insurance company will have a different procedure on how to do the appeal, but generally they must be filed within a certain amount of time after the denial. The first step in this process is to see if you should even appeal it in the first place. Sometimes the insurance company has good reason to deny or reduce payment. So you would really need to research or review the record to make sure that's not the case, okay? If you find that there was a coding error or something missing, you would just make the corrections and refile the claim. If the payer misinterpreted the clinical process or any of the coding guidelines or rules, or something like that, then you would prepare your defense, okay? And you would do that by providing proof that you are entitled to the payment, presenting information that was incorrectly interpreted or may not have been considered by the payer's reviewer, and then ensuring that the appeal is based on the payer's misinterpretation and not on an error on the part of the billing or coding departments. All right, let's see. Before you write an appeals letter, you need to have thoroughly looked at the denied claim, like all of the original coding and everything from the viewpoint of the denial, like the insurance company. This way you can try to see any and all reasons that caused it to be denied, and then decide, okay, should I appeal this or not? When you write an appeal letter, you need to clearly state what was done for the patient, how your facility complied with the contract with the payer, show that y'all did everything right. You also have to include background information on the patient and whatever the issue at hand was, what they're having problems with. There are 3 types of appeals: medical necessity, administrative, and coding. So depending on which type you have will determine what your next steps are and what you have to include in the appeals letter. So the first one, medical necessity denial, is usually on shorter length of stays. And for this type of appeal, you have to include a paragraph about the hospital's process for assessing admission for different levels of care. You also need to describe the doctor's intent with the admission, so what their plan of care was, and you want to be very detailed about all of this. Then you would end the letter with discharge information, so what meds did the patient start, what treatments and services will they get after discharge, things like that. If the appeal should be on the basis of an administrative procedure, then you focus on the doctor's intent to admit the patient as an inpatient and on the documentation that supports the doctor's decision to do that. For this appeal, the determination is whether the services provided were consistent with the definition of an inpatient admission. Could they have been treated on an outpatient basis, or no, they had to be inpatient. Okay, and then coding denials are usually related to documentation. So if you think the appeal should be made because of a coding issue, you have to provide the documentation that supports the DRG that was billed. If you think the coder picked an incorrect code, you usually have 30 days to correct it and refile the claim. And so in that case, you don't have to do an appeal. You're just refiling the claim with the corrected code. Okay, all billing departments are going to have a system in place to track and monitor denials and appeals, usually sorted by type of denial. And there are usually different people that are dedicated to work on each type, okay? The process will also track trends, like most common type of denial, so that they can get to the root cause and stop those types from happening. And then they also have a template that they use, one, to track denials, but also to write the appeals letters. So it makes it a lot easier on them. They just plug in the information they need for each case. Okay, and that is it for this chapter. Go do your bell ringer questions and let me know if you have any questions. See you next week.